When we find our judgment about a new advance in research, which then translates into the clinical setting, obviously it's very important not only to look at efficacy, which of course is our first important question, but it's also important to see, well, is there a price to pay for superior benefit? And I think that the trial results of the pivotal denosumab trials very consistently demonstrated that in addition to the better action, better efficacy of the antibody, it's also, in terms of tolerability issues and in terms of side effects, favorable treatment as compared to the previous standard. What I mean with this is particularly renal safety, which is obviously a great concern, particularly in the elderly cancer patients, apparently is not an issue when you use the antibody. Taken together with what I feel is very important for patients, the superior delivery mode. A subcutaneous action is always, injection is always more comfortable and feasible for patients rather than going to the hospital or to an oncology clinic and have a 30-minute infusion of something, having to sit down there, having to wait until the nurse or the physician has time. When we discuss how to translate clinical research findings into actual clinical decision-making, one of the toughest assessment methods is number needed to treat. That means how many patients do we have to treat in order to see a difference in one patient. In fact, for the comparison of denosumab versus zoledronic acid, in terms of the primary endpoint, this figure is about 12. And in terms of the endpoint, first SRE plus subsequent SREs, it's even lower, about 6. This is incredibly low. Usually, if we see tiny, maybe statistically significant differences, but sometimes we need 30, 40, 50 patients to treat before we can claim that one patient will benefit. With denosumab, with 12 and 6, this is a most favorable and actually very rare number, and it reassures us that there is a reasonable benefit which can be easily achieved when you apply this to general clinical practice. Given the way these calculations were made in the trials, based on patient years, the difference in number needed to treat versus number needed to harm is more than 15 times favoring the benefit, which I think is very reassuring to both us physicians as well as patients.